Wait, there were some really good grades, so good job, y'all.
High and low. Can I ask what's the high and low?
I'm sorry.
What was the high and the low? I'm nervous.
Why are you never relaxed?
All them salads are ridiculous. It was too many That's too many salads, especially if you
Oh,
don't
so I
even
was
get
like, what did
partial
you say?
credit.
Oh, for the I mean the select all that applies.
Yeah, salads, and you definitely get partial credit on the NCLEX and the HESI. But on the unit exam, you get no credit. It's not right.
So the only thing that I can do for that is bring that up. I can't do anything about the select all that applies. Oops, let's see. There's other people. But there were some really great grades, so y'all should be proud of yourself. Um, so we are going to finish up chapter 17. So we'll start with it's pages 240 to 247. So I will share my screen. I have the PowerPoints up. So we're going to dive into a little bit more about the LPN charge nurse position. Um, and so talked about LPNs can be in charge positions. Like I said last week, I've seen LPNs as charge nurses. I've seen them as unit managers. I've also seen them as even assistant director of nurses in some situations as well. So there's lots of room for leadership and management as an LPN. So one of the biggest things is, we look at experience. Um, Most of the time to be a charge nurse, it does require at least 1 year's or minimum of a year experience. It depends. I'm going to say honestly, that depends on where you're working because a lot of times they call LPNs charge nurses, like especially like if you're on an overnight shift. But it really, like I said, it's going to determine where you're working. Licensure, obviously, you're going to have a current license in your state of practice. And that includes if you get the multi-state or the compact license. So when you're filling out your application for the Board of Nursing, if you pick the compact license or the multi-state license, then you can practice in different states. Um, is everybody going to practice in the state that they're currently living in? Yeah. Um, so like I said, it depends on where you want to work and what you want to do. How close you are to a border, right? There may be some other opportunities available to you, if you live close to a border, that might not be right available to you. So that is something to look into as well. Um, and so as a charge nurse, you will collaborate with the interdisciplinary team. The goal is that you ensure that residents are receiving that high quality, low cost nursing care. Um, and so if you're working in a long-term care facility, who are going to be some of the other members of the healthcare team that you're going to need to work with? Excuse me.
CNAs or UAPs.
CNAs, UIPs. Okay. What else?
Positions.
Physicians. Absolutely. Absolutely.
Other nurses.
Other nurses. Absolutely. Have you all been to a long-term care facility and in like clinical setting or anything like that? Okay. So think about social workers, Social workers are the ones that work with, discharge planning. They also help them with other resources while they're in, like if they have to apply for Medicaid. There's a variety of different functions that they will serve. Activities as well. Activities is a big thing in long-term care, right? So residents aren't just sitting in their rooms all day, not doing anything or just watching TV. They do provide some socialization. And then, of course, you have your therapists, right? Your PT, your OT, your speech therapy. Those are all usually part of, part of the team in long-term care. And in some cases, you'll work with the registered dietitian, or dietary service manager, whichever is available. You also may assist in orientation of new nurses, right? So if you're a charge nurse and you've been there for a while, you know how the facilities run, you know the policy and procedures. So you may assist in orienting the new nurses, new CNAs that come in. And then another one is going to be evaluating your nursing assistant performance. So that is something that some may not be used to, right? Evaluating the work of other people. So other things that, you'll be responsible for. Know the conditions of residents of all times. So that's including your assessments, your evaluations of your residents. You'll know, what tasks that you can assign to your nursing assistants. You'll know, work on a day-by-day basis. You work with the nursing assistants. You'll learn real quick who the stronger ones are, who, may need a little bit more or a little extra help. But there's always going to be ones that you can rely the most on. Some organizations utilize what we call senior aides, right? Those are generally have been there for a little while, or lead CNAs, right? So they're kind of like the head CNA over the rest of the CNAs on shift. Provide care within your scope of practice, right? And that's going to be based off of your Nurse Practice Act, policy and procedures of the organization that you're working with, and then, of course, whatever physician orders come in. Recognizing symptoms of pending adverse developments, and then, of course, you need to report those. So, some of the even slightest changes in your resident's condition can be something very significant. And when you're working with people day after day, you get to know them, you get to know what their baseline is, right? Not just their vital signs, but what their baseline is as far as level of consciousness and affect, how they talk, how they walk, all of that. And so you'll be able to pick up on more subtle changes that may occur within them. Of course, administer medications and treatments as prescribed, maintaining proper documentation, right? So the electronic medical record is key. Making sure that you're providing whatever documentation that it is for your patient that's required, and that's based off of what policy and procedure is for that facility. Like with skilled care residents, those are, residents that may have had a heart attack, a surgery, a hip fracture, a knee replacement, a fall, something where their stay is going to be more short term. They are going to require like full documentation on a daily basis. With your more long-term residents, depending on the facility, some will practice the art of charting by exception. So maybe if you chart vital signs, right, and there's nothing else really going on with that resident, they may not require you to do like a complete assessment, unless there is a change in baseline. I always say be careful with that. You know, even if it's a short note at the end of the day, just to say that their vital signs were stable, they were alert and, you know, alert and oriented, they didn't have any changes. Sometimes that's super important. For, you know, the next shift coming in, should something, you know, different happen with the next shift, they can go back to that previous note to know that, okay, well, they were fine during this time, but now they've had a significant change. Appropriate and organized care in the department. How many of y'all have seen a nurse's station that looks like a bomb exploded on it with papers everywhere and just that's always my biggest pet peeve. Those situations, right? You can't even find anything that you're looking for. A lot of our nurses stations are out in the open, right? Family members, staff, residents, everybody can see the nurses station. And so it's, you know, it's really important to keep the nurses station clean, free of debris and clutter, making sure that there is no, PHI or, you know, protected health information that is just laying open for anybody to see. No medications, you know, no creams, no lotions, anything like that should be out at the nurse's station. Delegating to nursing assistants, talked about the rules of delegation. In addition to knowing what your scope of practice is within your state of practice, you will also have to know what the CNA's scope of practice as well as what the organization allows them to do. Talked about a little bit about patient privacy. And that's somewhat, you know, you know, if you're working in a small facility, you know, you don't want to be talking about residents in the hallway. In some cases, not loudly at the nurse's station either, because just of location. So like, for example, the last nurse's station or the last nursing facility that I worked at, it was there was 3 hallways, so like straight up and down, and then there was like a half hallway this way, and the nurse's station was in the middle. So it was right in the middle of everything, and then therapy was on the other side of the nurse's station. And so if you had to talk about a resident or even sometimes talking on the phone, there wasn't a whole lot of privacy just because of the nurse's station location. So, you know, fortunately, there was like another little office where if you had to talk to somebody that you could. But in facilities, there's people everywhere. There's always people coming and going. There's residents sitting around the nurse's station. There's family members. So it's really important that we're maintaining that patient privacy. And then maintaining dignity and ensuring the rights of your residents. And this is, you know, not, you know, how was the word I can say it? You know, make sure that everybody is clean, they're dried, they are dressed, you know, that we're not leaving them in precarious situations, sitting in the hallway. What do you need to know to be in charge? So the facility organization. So that's, you know, we talked a little bit about what is it called? I forget what the book called it. But like the chain of command, right? Kind of who's in charge. You will need to know the organization of the facility and, you know, where to go and what to do, you know, who to talk to when you need certain things. There are skills checklists for staff. You'll never get away from a skills checklist. You know, once you graduate and you think you've got all your skills, guess what? You're going to go start working and there's going to be a skills checklist for you as well. And these are things that are normally required yearly. And so your skills that you perform or are expected to form to do your job, you will have to be checked off on them prior to actually performing them. So a lot of times it's done during orientation. Whether it's, another charge nurse that's orienting you, the DON, in a lot of places, it'll be one of the educators. And the educator, how to change a sterile dressing, how to insert a Foley catheter, how to do trach care, how to suction trachs, how to give injections. Trying to think of what else is on the list. But it's, all of those things that you will do on a daily basis. And then job descriptions. So we talked about that as well. You need to know what your job description is. You also need to know what the job description of the CNAs that are underneath you, to know what each one is solely responsible for. And then regulations. So this is one thing in long-term care, and actually it's really any kind of healthcare facility. There's the policy and procedures for the organization that you work at, whatever the facility is. Then there's HIPAA regulations that need to be followed, right? They're the ones that, all your privacy laws, things like that. And then there's CMS, which is the Centers for Medicare and Medicaid Services, and they have their own set of guidelines that they require of you as a facility, as a nurse, to follow when providing care. And that's how they determine their reimbursement for, the services that you are providing for the client, as well as certain standards of care. We have the Joint Commission, formerly known as JACO. Has anybody heard of JACO before? The Joint Commission? Nobody? Maybe one. So Joint Commission is an accrediting organization that come out and they do separate inspections, other than, I'm sure, if you've been in long-term care, per long-term care state inspections is the Department of Health. They come out, they used to come out yearly. Since COVID, they haven't been coming out yearly. They've done a lot more of their visits as far as like documentation and other things they've been doing virtually. They've started to increase their presence. But Joint Commission, like I said, it's an accrediting agency. It is separate from the Department of Health. And an organization, whether it's a hospital or long-term care, they actually pay a separate accreditation fee for Joint Commission to come out. And they pretty much, they look at all of the standards of care. They look at all the policies and procedures, making sure that everything is working according to how it's supposed to be. There's another one, it's called DNV, and I do not remember what DNV stands for, but they are an overseas accreditation accrediting body, much like Joint Commission, that some hospitals have switched to over the Joint Commission. For long-term care, not every long-term care is going to be Joint Commission. So I worked for a company that we had 7 long-term care facilities, like 3 assisted livings, and independent living. And they only paid for one of the facilities to be Joint Commission. So they didn't pay for all 7 of the facilities to be Joint Commission. They only paid for one. So this is something that you may or may not see a lot in a long-term care. Definitely will see Joint Commission or DNV or another one of those accrediting bodies within the hospital organization. Your national patient safety goals. Does everybody remember your national? And no, you're not gonna, no, I'm not asking you to list them, but does anybody remember the national patient safety goals? Does anybody remember hearing about the national patient safety goals? So the national patient safety goals are, they are a set of guidelines that are established by Joint Commission. And the goals focus on specific areas where errors frequently occur. So I'm going to stop sharing my screen for a second. So with that, so if the national patient safety goals are guidelines that are aimed on specific areas where errors frequently occur so that we can try to prevent medical errors and improve patient care. Where do you think, give me an ideas of where specific errors may occur when providing care for a patient?
Medication administration.
Medication administration, absolutely. What else?
Maybe an error in their diet,
Okay, a diet
like
error.
allergies or the consistency of what they need for their diet.
Okay, okay. What else? What about infection prevention? You think that might be an issue? So some of the key areas of focus for your national patient safety goals: accurate patient identification. How many patient identifiers are we supposed to use when we are working with our patients? 2, very good. Good job, Samantha. 2, right? What are the most common we ask?
Name and date of birth.
Right, name and date of birth, those are the most common, but yes, you need to have at least 2 patient identifiers. Effective communication is another one. Improving communication among healthcare professionals helps to prevent errors as well as misinterpretations. Safe medication use. And so this is helping to prevent errors through improved processes and practices. So I always go to that poor med nurse in a long-term care facility, right? There, if you have a charge nurse and you have a medication nurse, right? The charge nurse is, responsible for, depending on where you work. So I'm just going to say charge would be responsible for things like patient admissions and patient discharges, care planning meetings, and more administrative stuff, and then of course supporting the nurses out on the unit. So a medication nurse is out, they're on the unit, they're passing medications, and what's happening with our med nurses. Patients or residents are coming up to them, family members, CNAs, the charge nurses, administration, providers. And so they often get interrupted performing their med passes very frequently, right? So what do you think would be some good ways to prevent the med nurses from being interrupted while passing their medications? Anybody have any ideas?
I remember seeing like a nurse that had on, it was like a vest, and the vest kind of said like do not interrupt.
Oh, really? That's pretty cool. I like that. That is a good idea, right? I remember watching the lead CNA, almost like a bodyguard to the med nurse, right? Just to help, steer other residents and staff away from the med nurses trying to pass for medications. A lot of it too is on, the med nurse themselves. We do try to take on a lot as nurses. And so even being able to just say, hey, I can't right now, I'm passing medications. Either, find somebody else that can help you, or I can come help you when I'm done passing medications. So there's a lot of things, even in the hospitals. And so your Pyxis or your whatever, medication distribution system that is being used in the hospitals. If you've ever looked in front of the Pyxis, there's like a box that is taped off. And the purpose of that is that when the nurse is in front of that Pyxis machine and she's pulling medications for her patient, that she's not supposed to be interrupted. And so go into the Pyxis, the doors, or you go into the room, the doors closed, it's locked, you go to the machine, you're able to concentrate on pulling your medications, and not be interrupted while you are standing in front of that Pyxis machine. And so I've seen it, and I'm sure everybody else, people are in there trying to pass medications, and nurses and others are coming in and interrupting. So we really need to kind of, refocus some of that attention and, making sure that we are, focused on the task at hand to try to prevent those errors from occurring. The safe alarm systems. Has everybody heard of alarm fatigue? Alarm fatigue, whether it's in a hospital, whether it's in a long-term care, the call bell system, right? You're out on the unit, you're sitting at the nurse's station, and the call bells are continuously going and going and going and going. The biggest issue with that is with alarm fatigue, they tend to go unnoticed or ignored. Or in some case, the response time to the call bell is a little slower. When a person hits the call bell, that's for their safety, right? There's usually something they need, whether it's to use the bathroom, to get out of bed, for pain medication, right? Variety of reasons why somebody would put a call bell on. And what has happened is when those call bells go unresponded, or even in the hospital with bed alarms, right? People try, after, not getting a response for a call bell, they'll try to get up unattended, and what happens? They fall and they hurt themselves. So these are things, when a call bell goes off, you respond to the call bell. Even if it's just peeking your head into the room, making sure they're safe, asking what they need. If it's not an immediate need, right? Explain, I'll be back in just a few minutes. What are some things that we can do for infection prevention? What's our first line? What's our first thing that we are always going to do to prevent infection?
Hand washing.
Hand washing, right? So a lot of your hospitals, they have either a wash in and wash out, or a foam in, foam out, whatever they want to call it, right? Where you sanitize before you go in the room, you sanitize on your way out of the room, right? That helps to prevent you from spreading infection to another one. How many of you wipe your stethoscopes down between patients? I saw that look, Samantha. Believe it or not, you would be amazed how many people do not wipe their stethoscopes down in between patients. That's almost as bad as not washing your hands, right? Because what are you doing? You're, with one patient, you're doing your assessment, you're listening to the heart, lungs, you're listening to their bowel sounds, whatever it is. And then you put your stethoscope back around your neck, which now all their germs are right there in your face, or you put it in your pocket to be used for the next patient. and you may wash your hands, but once you pull that stethoscope out, right, you're just ready to infect the world. So that's a big one too. Wiping your stethoscope down. What about your pens? How many wipe their pens down? It's really kind of the same thing, right? You go into a residence room, you have a clipboard, you have your pen, a piece of paper, whatever it is, and you're writing with it. You're putting, doing your assessment, continuing to write with your pen. You walk out of the room, go into the next room, still have that same pen. So infection prevention, other things that we look at to prevent infection, make sure you're doing your stole dressing changes. Foley catheters, oxygen tubing should not be touching the floor. They should be all off of the floor. That includes when they're up in a wheelchair. Making sure the tubing doesn't touch the floor. Tube feedings don't touch the floor. Wound vacs as well. You don't want any of that tubing touching the floor. There's very few medical devices that we have that should be touching the floor. And the one big one that comes to mind, and I had a hard time with this when I was a new nurse too, is chest tubes. That chest tube container actually needs to sit on the floor. And so we spent all this time telling you nothing sits on the floor. Chest tubes can stay on the floor. And that's just because they need gravity to help them do what they're doing. Preventing mistakes in surgery. Anybody want to go into the OR or be some sort of a surgical nurse? Yeah. So that's, another big thing. I don't know if anybody has heard of To Err is Human. To Err is Human was written back in 1999. And it was looking at all of the errors in healthcare. And so it wasn't just medication errors, it was same or wrong surgery. Trying to think of what else. It was wrong surgery. It was medication errors, just medical errors in generally. But it was, looking at the consequences of those errors, not only for the patients and families, right, but to healthcare itself. And so they did this huge report in millions of dollars a year in medical errors, wrong site surgeries, things like that. And they did a follow-up 20 years later. And even with the safeguards, like, I told you about the taper on the Pyxis and, other things that they had done, there's still a significant amount of medical errors. We didn't even really make a dent. And so they've done, they have like timeouts in surgery prior to the surgery to make sure that they have the right patient, the right equipment, the right surgical site, all of that. I've had surgery, and my doctor has come and literally just wrote on on my foot on my ankle, he wrote his initials. The nurse wrote her initials so that when I went into surgery, they didn't see their initials. They knew they were on the wrong site, right? But we've heard of things like wrong legs being amputated, wrong infected kidneys being removed, right? So these are all things, but surgical markings, timeouts is one of the ways that we are trying to combat that. Patient safety risks, this is another, this is not just, bed rails, bed in the lowest position, making sure that everything is within reach for them. But it's also about assessing mental status, things like suicide risk, right? Your depression scales. And then of course, another one, a big one is trying to improve health equity, right? Trying to address some of those disparities in healthcare access for, all patient populations. So those are some of your national patient safety goals. In some of the textbooks, you may see little boxes about the NPSGs. All right. So going back, so what do you need to be in charge? What do you need to know? So personnel policies is another thing. Um, every facility, everywhere you work is going to have some sort of an employee manual, kind of like your student handbook, right, for school. Um, timesheets, whether it's an electronic time management system, or paper, which I hope nobody's using paper anymore, but what are the payroll policies, leave and time off, right? How long do you have to be there in order to start accruing PTO, right? Or, you know, what happens when you get sick? What's the requirement for calling out sick? Is it an hour before your shift? Is it 2 hours before your shift? Those are super important to know. Communication and reporting. What do you think would be some sentinel events that we would need to immediately report if we are working in a long-term care facility? Anybody?
Like a fall that caused death?
Okay, a fall with death. We can, it's even a fall with fracture. We can, yes, and we've had people fall and that has caused death. But yes, any kind of a fall with a fracture is going to be any type of abuse is also an event that needs to be reported. Um, and so again, it just depends on the situation. Communicate and like who you report to is going to be determined by your facility. So most cases, right, as a charge nurse, you're going to go to, the unit manager, the ADON, the DON, in some cases, the administrator. With certain sentinel events, they only have a minimal amount of time in order to report that. So that has to be done very quickly. Communication is key. This is where you're going to use your SBAR, especially when you're talking to, when doing staff turnover, when we're talking to the providers. Why would smoking policy be a problem, be something that you need to know? About
Did
the
you say
payroll.
smoking?
Smoking?
Is that because of oxygen being
Yes.
used? Is that, yeah.
And then some facilities still have smoking um for residents that have been there for a while. Most no, sorry. Most healthcare facilities are smoke-free. But there are some facilities that were previous, the residents used to be able to smoke, right? And then they went smoke-free. So some of them were grandfathered in. So smoking policy, right? We actually have, some facilities that they do still have residents that smoke. And what's the policy for that? Do they have to be supervised, unsupervised? There's also things like smoking jackets that people can wear. It's a fire retardant drape or apron that we put over them that in case something happens, they don't get burnt. Break rules, also important. Personal device uses, right? Cell phones is probably the biggest one. And that is one of my biggest pet peeves is going into a facility and you see the med nurse on the phone, constantly talking to, whoever, not work related. And that not only could be a HIPAA violation, right? But it's also distracting you from what you're supposed to be doing. And then, of course, the uniform. Depending on where you work, they may have color-coded uniforms. Some facilities may allow you to wear whatever color you choose. And then, of course, things like routines for each of the shifts, days, nights, evenings, weekends, procedural manuals, the nurse, how to use the nursing care plan, how to use the Pyxis, if you have a Pyxis in the Cardex system, um, care conferences or care plan meetings. These are something that are usually held weekly. Each person or each resident in a long-term care facility has a care plan meeting at least once a quarter, just to go over their plan of care, look at the interventions, the goals, allow the resident and the family members to ask questions, identify concerns. Of course, they can identify concerns anytime, but this would be, another time. And it's usually social work, nursing, in some cases, dietary will be there as well as activities. If they are receiving therapy, a member of the therapy team will be there as well. So that it's, everybody that, can answer questions. Transcription systems. These are primarily for providers, where they're transcribing their notes. Some providers will put the notes directly into electronic medical records. Others will dictate and then have their notes transcribed and sent to the facility. Other things, admission processes, how to do an admission, how to do a discharge, how to do a transfer. When residents come in to a facility, I'm so sorry. They need to have a full head to toe assessment, right? As well as a complete inventory of all of their personal belongings. So it is recommended, right, that anything expensive be sent home with a family member, just to prevent anything from happening. But we do a full detailed list of the inventory, how many shirts, pants, socks, underwear, jewelry, computers, laptops, iPads, whatever it is they bring in, and hearing aids, glasses, dentures. Hearing aids and dentures and glasses are probably the most misplaced things in a long-term care facility ever. Glasses, they put them down on their breakfast tray, they get sent down to the kitchen, or dentures, the same thing. They'll take their dentures out after they eat and leave them on the tray, and you're not paying attention, you might throw them in the trash, right? So, and hearing aids. Oh, I can't even tell you, hearing aids are so small that they often can get misplaced as well. So really paying attention to that. I had a resident actually who took his hearing aid out and was chewing on it. I don't know if anybody's ever worked with hearing aids, but I could hear the whistling, like the volume was turned all the way up, and I could hear it in the hallway. And I'm like, oh my gosh. So I go in there and I'm like trying to talk to the resident. He was completely nonverbal. He was end stage dementia. He was nonverbal, but I could hear the whistling. So I'm like looking at it, and it's not in his ear. And I'm like, it was in his mouth. He was chewing on it. And so I'm like, okay, let's not do this. But yes, so, need to know where these things are. What are the care care procedures for taking care of seriously ill patients? What are the death procedures? Autopsy, forms and authorizations for procedures. So it depends on where you're working. So in long-term care, we get a signed consent that is going to cover the procedures that we would perform within that care setting. So, medication administration, blood draws, the occasional IV stick, maybe a Foley catheter. But anything other than that, they would have to require another authorization. So if they were going to go out for a surgery or another procedure at the hospital, then we would have to get consent for that separately. What are the visiting hours and notary service? Some facilities will have a notary public, usually like the business office manager, in the case there is a notary that is needed. And then, of course, safety. What's the bed rail policy? I will tell you, for long-term care, there's no bed rail policy because you're not allowed to have them. You're not allowed to have bed rails. In some cases, they may have the little like quarter length side rails that are at the top of the bed. And those can be used if the resident can use them for turning and positioning in bed or assistance sitting up, things like that. Chair and bed alarms are not used in long-term care. They are considered a restraint. But we do use bed alarms in hospitals, right? Especially those that are at a fall risk. Restraints, same thing. We do not use restraints in long-term care. Hospital systems are a little bit different. Restraints are both mechanical as well as physical. So make sure that you understand that it's not just about putting, the wrist restraints on your medications that we, would use are also considered restraints. So we do have to be careful with that. Oxygen. So in a hospital, your oxygen is piped in the walls, right? So if you need to put a resident or a patient on oxygen, the oxygen is right there in the wall. In long-term care, we rely on oxygen concentrators and oxygen tanks for the most part. In nursing action, you can apply oxygen, but you have to have a doctor's order within 24 hours of applying that oxygen, as long as you did it with your nursing knowledge. Patient transfer and transport. This is how, how does the patient transfer from bed to chair, sitting, standing, all of those things. Do they need a Hoyer lift? Do they need to use the sit to stand? Are they a one-person assist or a two-person assist? How do they get around? Are they able to walk? Do they use a walker? Do they use a wheelchair? When you're pushing a person in a wheelchair, make sure you always have foot pedals on the wheelchair and do not push them without foot pedals. If there's no foot pedals on the wheelchair, and we've had this happen, and that's why, asking them to hold their feet up isn't always possible. Okay. They may not be strong enough, or halfway down the hallway, they may forget and put their feet down. And we actually had a resident that broke her tib fib because as she was being rolled down the hallway without the foot pedals, she put her foot down and it got caught underneath the wheelchair. You can also not pull them backwards in a wheelchair. So if there's no foot pedals, you can't just pull them backwards. That's a dignity issue. And of course, for nurses, back safety and body mechanics. Back injuries are the most common injury in nursing. So that's why we always try to teach you guys the best possible body mechanics, right? Put the bed up to your working position, good working position. Make sure that you have a good stance, that you're not trying to pull up a 400-pound patient by yourself, right? And door alarms are also really important. Especially with elderly population and some of our wandering patients. We actually had a resident, this was years ago, had a wander alert. And what happens is when they get to the door is supposed to lock automatically and the alarm goes off. But because for fire safety, right, there's, I think at the most, or it's like a 30-second delay. Some it's a 10 or 15-second delay. It just really depends. Just enough for a staff member to get there to redirect the patient. Well, it was a 3 to 11 shift. The door alarm went off. Nobody responded. And the patient was able to get out of the building, was on a busy street, got hit by a car, transported to the hospital. And 2 hours later, the hospital called the facility and was like, are you guys missing a resident? They still had no idea that the resident was missing. And he ended up passing away from his injuries. So that's why when I say alarm fatigue is real. Of course, standard precautions, right? And then what are the security measures that are there, within that within the building? How to use the equipment, right? So how to use the oxygen, whether it's a concentrator or the oxygen on the wall, or if it's an oxygen tank, how do you apply the regulator on top of the oxygen tank to secure it, as well as to, open it and turn it on. How to use suction equipment. In the hospital, suctions built into the wall. In a long-term care facility, you may not have that luxury. You may have to use a portable suction machine. So how do you use the equipment? I am not going to lie. First time I had to use the suction equipment when I was a brand new nurse, I had no idea. I could turn it on, but I didn't know which those tops had like 3 different holes. I didn't know which hole to put it in order to get suction. And then when I did do it, I still didn't get any suction because I didn't put the other piece on the little tube to allow for the suction to even occur. So that was something that was very frustrating, right? So how to use the equipment? Where is the crash cart? What's on the crash cart, right? Nothing worse than, having a code blue or another type of emergency, right? And you don't know where anything is. How to order their diet from dietary. So this is the big one. I've seen this happen too many times, where a resident gets admitted maybe late in the afternoon, and during the admission process, the slip never gets sent to dietary. So now this poor soul has not had dinner, and you're scrambling to find him food. And then even worse, they may not get breakfast the next morning. So knowing how to do that. And then what are the special diets? You've got a million, I feel like there's a million, but there's a variety of different diets out there. You have puree diets, you have mechanical soft, right? You have regular diets, you have low sodium, you have heart healthy. You have your diabetic diets, there's low purine diets, right? There's a bunch of different diets out there, making sure that you're getting the right diet for your clients. And what are the feeding policies? Who feeds, when they feed. One big thing when you're working with patients in long-term care that are sharing a room, if you have 2 residents in a room, they have to receive their trays at the same time. So if one's a feeder and one's a not, they have to still be fed at the exact same time. What are the processes for the dining room? And are there procedures for family trays? So if Mrs. Jones' daughter wants to come in and have lunch with her, can she order a tray from the dining room or not? And then of course, your other procedures, your ADL care, your showering. Most residents in a long-term care facility get showers twice a week. So showers are split up amongst all shifts. Making sure oral care, bed making, vital signs are done. You also need to know how to do a catheterization, whether it's in and out for a straight cath or a Foley catheter. How to do enemas, suppositories, measure I&Os, who's the lab services. So, do you have to draw your own blood? Is there a lab service that comes in and takes the blood? And then procedural assistance. So most facilities have some sort of a wound care provider that comes in, either a nurse practitioner or a doctor. And if there's not a specified wound nurse at that facility, does the charge nurse have to follow the wound care provider while he or she does their rounds? How to do colostomy care, how to monitor glucose, NG and G tubes, post-mortem care, and then standard precautions is always going to be a big one. Post-mortem care is going to be a standard policy and procedure. One thing that you need to be aware of when you're doing post-mortem care is always look at, ask family what their preferences are. Because there may be some cultural, religious processes that need to be taken into consideration when you're providing postmortem care. So especially if a patient is declining, you want to talk to the family about that to make sure that you aren't going against any of their wishes. Medication, biggest one is going to be your NARC count. If you have an automated system like Pyxis, right, it does the narcotics count for you. In long-term care, the narcotics drawer is the narcotics drawer, and it has to be counted every time there is a change of nurse. So if it's at change of shift, or if one nurse has to leave early for another reason, another nurse is taking over, then that nurse needs to count out that part and make sure that the narcotic count is appropriate. Also need to know what to do if, the count is off, or if there's any medication errors. Remember, with a medication error, the primary responsibility is to your patient to make sure that you're monitoring for any adverse effects. Documentation is everybody's supposed to be on EMR now. So unless there's a power outage, computer downtime, something along those lines, everything should be done in the EMR. Some facilities may have small paper records, but majority have converted over to EMR. Are there any special forms like shower seats? We use our shower seats with our CNAs. So when they give them a shower, they give them a bed bath, and they there's anything on their skin or bruise that wasn't there. That is their way of reporting it to the nurse. Flow sheets, those are for like INOs, monthly weights, vital signs, what are the phone order procedures, fax, email. This is another nice thing that's really good with EMRs. Most providers have access to EMR so that if you call them with an issue and you need an order, they can just log into the EMR and they can put the order in, or they can give telephone orders over the phone as well. Incident reports. Anytime, there's an issue and you complete an incident report, do we document incident reports in the client's charts? So if Mrs. Jones fell, do I write in the chart, Mrs. Jones found on floor, whatever the case may be, incident report complete? Why? Why do we not document that? Anybody know? No. All right. So incident reports are internal documents. Okay. These are documents that a facility is going to use to try to improve processes. So if Mrs. Jones falls, we are going to do an investigation on why Mrs. Jones fell. What were the things that led up to the fall? And we're looking just to see what's going on. We're also going to look, was there water on the floor? Was there a cord on the floor? Was there, something in her way? Whatever. We're going to do this whole investigation and we're going to identify what the issue was, and we're going to try to look for ways to prevent it from happening again. Those are internal documents. Those are things that we do within the organization. If we wrote that an incident report was completed, then an inspector from Joint Commission, DND, Department of Health, they can ask to see that incident report. And we don't want them to see our internal forms, right? Because what if this is just a totally out there? What if it was the nurse tripped Mrs. Jones, right? We don't want that. We don't want the state to know that. I mean, they probably would already know, but I'm just, trying to think of something. Or, there was water on the floor and the resident slipped and fell in the water because, we just left it there and we didn't mop it up, right? Whatever the reason is, we don't want them to see our forms. We don't want them to see what we did. They know what happened. But if we put it in their incident form or completed, then they can ask to see our internal form. They know they're there, but unless they know, then they can't ask for them. And the only way they can know is if we put it in there or we tell them. And then specialists like wanderers, hearing aids, dentures. Like I said, hearing aids, dentures, and glasses are among the top 3 things that go missing in long-term care. Clothing too. Everything should be labeled, marked with their name on it. But we may keep a list of patients that are wanderers, that have hearing aids, that wear dentures, just so that we can remember to check to make sure that they're there where they're supposed to be. With wanderers, we do as well, because you'll always have it in the back of your mind. If you start seeing them, start moving around, you'll be more cognizant, listening in case there's an alarm that goes off. And then collecting data for your residents. This is part of your assessment when you're, admitting a client. Your vital signs, height and weight are key to obtain when they get into or they are admitted, so that we have a good baseline. And then you're going to do your complete health, head to toe. Your mobility assessment in long-term care is generally done by a physical therapist. Communication. We are going to assess their communication. In some cases, we may need to employ the assistance of speech therapy interpreters. And then, of course, your cultural, religious, your psychosocial, right? That's a big part of our assessment. Employee home problems. Oh, I was like, I've read this wrong. So as a charge nurse, we are going to be the ones that are going to get the call out. We are going to be the one that, may be the ear for the team or for, anybody that is experiencing issues. Don't offer advice, don't try to counsel, always just try to, suggest resources for them. If there is like an employee assistance program, human resources is another good resource for, if somebody that you're working with is having any issues at home. Encouraging responsibility. You're always going to have somebody that is working with you that absolutely knows how to do something, and may try to get, no, I don't want to do it because I don't know how. This is where that see one, do one, teach one is always going to come into play. So the first time they say that they don't know how to do something, you're going to show them how to do it. Then they are going to do it themselves, and then they are going to teach somebody else how to do it. It's empowerment, right? It's encouraging them to be responsible. It also, allows them to take ownership of things. And then we will praise. and reinforce. And so, and then document. You want to document that they were taught the procedure, that they know how to do the procedure, that it's within their scope of practice, so that if they try to come and say, I don't know how to do that again, you have documentation to show that you had already shown them how to do it. Let's see. All right, so the last couple slides are about family. So how many of you have had to work with a family member of a patient? One. How many of you have been a family member of a patient? Okay, so what are some things that family members feel when it comes to their loved ones being ill or in the hospital in long-term care? What are some of the feelings that they have?
Sometimes they feel guilt that they had to put them there. You know, I think that's number one.
Guilt.
Sadness, guilt, yeah.
I like that. That's a good one. Guilt is, right? That's a big one for a lot of people. Um, they may have all these high expectations about trying to keep them at home and caring for them, and then realizing that maybe the needs are too much for their loved one. So how do you think we should relate to these families? How should we treat our family members?
Well, with kindness and empathy, not sympathy, but empathy and yeah, I don't know.
So nurses in long-term care, CNA in long-term care, therapists, everybody tries to do the best that they can, right? It's often, it's hard work. It's very hard work working in long-term care. I'm not ever going to say that it isn't. And it is a combination of guilt. It's a combination of a lot of different feelings when we're working with patients and their families in a long-term care situation. And then you throw things like dementia or Alzheimer's disease on top of that, and it's a downward spiral, right? There's a lot of other mixed emotions that go into that. Because their family member no longer recognizes them, right? They don't know who they are, and the family just wants their loved one, right? Um, and so there's a lot of different emotions, which is going to be presented in a variety of ways. Some of the families are going to be the kindest, most wonderful families that you've ever met. And some of the families are going to be the ones that are going to nitpick on every single thing that you do, right? There wasn't hospital corners on the bed, right? There's a pea-sized stain on the sheet, right? No matter what you do, they're going to be. And we have to look at the reasons behind that. And that's usually where guilt is going to come into play. And so it's easy. You can see where, if you're constantly you're not doing this right, you're not doing that right, you're not doing that right. It can be very frustrating as a nurse, right? To have to deal with families like that. But we have to kind of understand their point of view to see where they're coming from. Allow them to talk, allow them to express whatever their concerns are. um, you know, they will get a clear set of expectations when during the admission process, right? When they're, getting the admissions process set up, they'll get a patient bill of rights. They are going to get a list of this is what we are going to provide for them. But if they do come to you with a true complaint, with a true issue, one of our goals is to try to, right, fix the problem. So, is it something that can be fixed right away, or is it going to be something that has to take some time in order to fix? And so really listening to them, using your active listening skills, right? Making sure that you understand the true situation at hand. And then provide them a solution that is going to be amendable for both parties. And so, the best thing is to try to develop as good a rapport with your families and your residents as possible. And you want the families to be involved, because family involvement in long-term care can be very beneficial, right? Not only for the resident and for the family, but for staff as well, right? Because some of the basic needs can be met, right, by family, even if it's just sitting there and spending time with the resident, talking to the resident, right? Interaction with the resident, not saying that they're going to provide care, but that, helps to know that there's somebody with that resident. And we've had residents that were either like chronic fallers, um, or, I had a couple that they just, if they felt that they were not getting the attention they needed, they would throw themselves on the floor. Okay. So having family members come in and sitting with them, they're getting the attention that they need, right? And also helping to prevent injury. So you can utilize your families as well, just by developing that really good relationship with them. But again, and with Alzheimer's disease, and I know when med-surg, I'm sure, or in mental health, have talked or will talk about Alzheimer's disease. But with Alzheimer's disease, unless there's something like another comorbid disease process that is going on with it, they're okay. Like they're okay. They, like I said, unless they have another comorbid disease process or have had an injury, they're not in pain. They're not suffering, right? They're really okay. They're in their world, right? And their world to them is fine, right? It's us. It's us that have the hard time, or the family that has the hard time, because they just don't remember us anymore. They don't remember the families anymore. But generally speaking, as long as their needs are met, they're not suffering. And then, so that's something that we need to tell our patients' families, our residents' families, that they really aren't suffering, because they just, like I said, they're in their own world. And so, they may tell the same story day after day, day after day, day after day, to where you know the story by heart and could probably say it with them. But that's the hardest part, is the fact that they don't, they don't remember their family. And the family is trying to hold on to that. And so, just kind of learning, and educating about disease processes like that also may help your families understand what's going on. And then of course, there's always, the other aspects with, the dementia that they could develop, the agitation and aggression. But that's not the majority. That's the minority of your Alzheimer's patients. So that is something that hopefully not, most families won't have to deal with that. But it is always a possibility. What else? We talked about end of shift report last week. All right, so that is it for chapter 17. What questions do you have for me? Did the test just wear you out, or?
Yeah, the test is too much. Can I speak with you after class?
I have a couple of people that'll be meeting with me after class.